So as Professor Orlando said, dry eye is an immune-based inflammatory disease that results in a chronic pain syndrome. And so this slide was given to me by Dr. Jim Aquavella, who is a very well-known ophthalmologist from Rochester, New York. And you can see here that this gentleman lives in a very dry environment. He has very severe dry eye, and it results in chronic pain. So in order for him to actually look at you while he's talking to you, and I hope this is okay for the people on the right side, but I'm pretty old school these days, but you can see that he puts a stick in between his eyelids to keep his eye open so he can see you, but when the pain becomes too severe, then he can pull on the little string here and his eye is able to shut and form a more normal environment on the ocular surface and restore some comfort. Okay, so this is the lacrimal functional unit, and this is all about how we maintain a normal homeostatic environment over the ocular surface. This is a concept that Steve Flugfelder and I came up with many years ago, and it is actually in our book. But it starts out with what Dr. Orlando referred to as the ocular surface system. We can see here the ocular surface, and one must understand that the cornea is the most densely innervated surface in the body. It is 40 to 60 times more densely innervated than tooth pulp. There are no synapses there. They are all free nerve endings, and they are there primarily to allow us to understand when there are intrusions on the ocular surface. Pain is obviously what they are there primarily to show, but subconscious stimulation of these nerves results in afferent nerve traffic through the V1, the ophthalmic branch of the fifth cranial nerve, or the trigeminal nerve, and this nerve traffic ends up in the central nervous system, here in the midbrain, but also is integrated with input from the cortex. So when we think about things and our moods, we can actually affect our tear flow. And once that integration takes place, we then have efferent nerve traffic through the facial nerve, the seventh cranial nerve. And the important thing to understand here is that nerve fibers from this nerve tract will end up around the main and accessory lacrimal glands, the glands of Wolfram and Krauss, which are the accessory glands and are responsible for most of our daily tear flow. But also fibers from this tract are around the meibomian glands and around the goblet cells. And really what this tells us is that what we secrete on the ocular surface is very tightly controlled. And as Dr. Rolando said, this is not a disease of dryness. This is a disease of tear film composition and maintenance of the ocular surface system. Okay, so one of the big findings over the last 15 years is that tears have changed. So we used to think of tears as a sandwich, essentially, where we had lipid on the surface, secreted from the meibomian glands. We had mucins on the surface of the eye, and here is in between was the aqueous. And now we know from work done by Roger Byerman and others, this was mostly multi-TOF mass spec, has shown that there's about 1,500 different proteins in the aqueous of the tear film. And these tear components have two major functions. One, of course, is anti-infective, and then the other one is to be trophic and maintain a normal environment to the ocular surface tissues. But in dry eye, the picture looks very different. So here we have what a tear film would look at like in dry eye. And so first thing you notice is that the lipid layer on the top has changed. Biochemically, people have looked at these lipids. They are altered. The profile is very different, and they are incompetent to form a normal seal across the ocular surface, and therefore we get loss of aqueous. So you can see there's lots of evaporation here. Once that happens, the tear film concentrates, the salt level goes up, the osmolarity increases, and any of the inflammation that is there is now ramped up and increased. And you can see here that we have activation of the pro-inflammatory cytokines, and in addition to that, we have loss of mucins on the ocular surface. You can see there's a lot of shedding of cells, and so we have a very pro-inflammatory environment across the ocular surface, which is really what dry eye is, and it hasn't escaped our notice that, in fact, once this seal is broken here, once these tight junctions are compromised, then there is access to all of the nerve endings there in the ocular surface, and then that generates pain. Okay, so here is a picture that was actually given to me some years ago by our next speaker, Dr. Calonge, and you can see lissamine green staining of the conjunctiva here, and if you look at the tears and the ocular surface and you take biopsies and impression cytologies, you will find the presence of pro-inflammatory cytokines and chemokines. There is an upregulation of class 2 antigen, and we're going to talk about why that's important here in a minute. elevation adhesion molecules, such as ICAM1, has been seen in dry eye. It's always there in low concentrations, but it is very much involved in homing to the ocular surface in this disease. And of course, we have inflammatory cell infiltration of the conjunctiva and the lacrimal gland. So just to demonstrate that this, in fact, is an inflammatory disease, the bars in light blue and dark blue are from dry eye patients, left and right eye, and the gray and white bars are left and right eye from normals. And you can see that every one of these particular cytokines that have been looked at are always elevated in the dry eye person over the normal. Okay, so this is a slide from Steve Flugfelder from Baylor College of Medicine, longtime friend and collaborator of mine, and you can see here in the normal eye, if you do an impression cytology and stain for class 2 antigen, what you will see is essentially the Langerhans cells. That's why this is LC. These are the dendritic cells on the surface. You can see how they light up for class 2 antigen. They are ready for a rapid immune response in case of an initiation of an autoimmunity of some sort or an intrusion of a bacteria or pathogen. But if you do the same thing on a dry eye patient, what you will see is not only the Langerhans cells, but in fact the entire epithelium now lights up and is presenting antigen, and that is sort of the basis of what dry eye is all about. So let's talk about what the cycle really is here. You have the ocular surface, as you can see here. Okay, and on the ocular surface, you have an entire population of immature dendritic cells and antigen-presenting cells. This was found by Dr. Reza Dana at Harvard, and they found, we used to think it was just on the conjunctiva with just those Langerhans cells, but now we know that the ocular surface is essentially replete with large quantities of immature dendritic cells waiting to perform a rapid response to any intrusion. So we have the ocular surface here, and in fact, if you stimulate the ocular surface, and we developed a model using a fan, but there are different ways of doing this, certainly with infection, but you can see here that you stimulate the ocular surface, and the first thing that you get is an innate immune response. This is a non-specific response. It is essentially a cytokine storm. It's the eye's way of saying there's something wrong here, and I want to get rid of it very quickly, and I don't really care what it is. So it's a very rapid response. It occurs very rapidly. And in fact, we have upregulation of ICAM1, as we talked about, which is why we're here today. Also, class 2 antigen is upregulated. And then what happens, and I'll talk about this in a little more detail, but what happens here is these antigen-presenting cells accumulate the antigen, process it, and leave the ocular surface via the lymphatics, and they end up in the draining lymph node, as you can see right here. And that's the end of the afferent response of the adaptive immune response. So we've had the innate response, and now we're doing something much more specific. The body is attempting to get rid of a specific antigen, and it goes to the lymph node, and there it encounters, as we'll see in the next few slides, a population of naive T cells. They're formed, they don't really know where they're going to be assigned to go yet, what the mission is. Once they're exposed to the antigen and the environment is changed within the lymph node, these cells are primed and targeted, and they will then leave the lymph node via the circulation, travel back to the ocular surface where this antigen is also being expressed, as we saw, and they will create a chronic inflammatory disease. And as long as there is antigen on the ocular surface, this disease no longer needs the stimulus. We now have a chronic disease process ongoing on the ocular surface. Okay, so as you can see here, this is a more detailed version of what happens, and we'll go through this in detail. This is sort of the circle, what we would call the dry eye complex autoimmune-based chronic inflammatory disease. So it starts out here on the ocular surface, and you can see the immature dendritic cells there, and those immature dendritic cells are activated during the innate response, and you can see that there's all sorts of cytokines and whatnot exposed there, chemokines, cytokines, the entire inflammatory milieu. But as that's happening, we then have a mature dendritic cell, a maturing process, because this cell now has an antigen. It is processing it and putting it out on the surface, and this cell will use a chemokine called CCR7 to free itself from the ocular surface and to enter the draining lymph node. And so here we are within the lymph node, and these cells will pop out, and they will interact with all of these Th0 type cells, and they then will become Th1 cell, where Th1 cells secrete primarily interferon gamma, and then there will also be these Th17 cells, which secrete IL-17, but in addition, Th17 cells are very much responsible for interfering with T regulatory cells, the anti-inflammatory T regulatory cells, so they allow the immune process to continue. And then lately we've also found out that, lo and behold, the B cell is also involved. So the B cell will interact with these Th2 cells, and if there's no allergy present, the Th2 cell will then just cause the B cell to mature into a plasma cell, and these plasma cells will then secrete antibody. And so when they get back to the ocular surface, as we see here, they enter the they leave the circulation, and they do that by adhering to ICAM1. These cells express LFA1 on their surface. They will diapedese or come out into the stroma of the conjunctiva, and you can see here that the Th1 cells are secreting lots of interferon gamma. We have the Th17 cells secreting IL-17 plus matrix metalloproteases, and we all know that MMP9 is one of the biggest factors in dry eye. And in addition, we then have these plasma cells here, and these plasma cells are secreting specific antibodies, and we now have a chronic adaptive immune response, and that's what's occurring within the ocular surface, as Dr. Rolando said, and we then have this chronic inflammatory process that we know to be dry eye. And so that is essentially the story, and these are all the people that did all the work, and some great collaborators that many of you will recognize. And I think we can then move on to our next talk, and this is from Professor Margarita Colonge from IOBA at the University of Valladolid here in Spain. And she's been doing this for a long time, and they now have actually a very nice dry eye chamber there where they're doing lots of clinical trials as well.